Dr. Yogeesh Kamath, a distinguished specialist renowned for his expertise in hip and knee joint replacement and sports injury. His remarkable career is punctuated with a plethora of accolades and achievements. He has he has done his MBBS from University of Mumbai. He obtained a fellowship in orthopedic from the College of Physicians and Surgeons, Mumbai, and he also obtained a diploma in orthopedic from College of Physicians and Surgeons, Mumbai. He also has DNB orthopedics from National Board of Examination. He also obtained fellowship in trauma and orthopedic surgery from Royal College of Surgeons of Edinburgh, UK. His work experience includes he worked as a consultant at different hospitals, including Lokmanya Tilak Municipal General Hospital and Medical College, Mumbai, KEM Hospital, Mumbai, and currently he is working as a consultant in KMC Hospital, Mangalore. Among these, he has awarded the Yellow Belt for a leadership project at Royal Survey Country Hospital in the year of 2013, and in 2003, he secured the gold medal at the Doctor Ortho examination among 322 candidates. Dr. Kamath's commitment to excellence is evident through his achievements, such as receiving the Best Intern Award at LTM Hospital and Medical School in the year 1998. With a track record of excellence and dedication to providing exceptional care, Dr. Kamath stands as a pillar in the field of orthopedics. We also have Dr. Biswarajan Das. His qualification includes BPT, MPT. He is also a research scholar. He is doing his PhD under the guidance of Dr. Kamath. And we also have Dr. Khyati Verma, Assistant Professor, Department of Mechanical Engineering, NITK Suratkal. I heartily welcome all of you. Over to you, sir.
Thank you very much indeed. Thank you for assembling to this. Thanks, Professor Shekhar, for such a warm invite and a wonderful interaction, actually. It is common for us, usually as a teacher, to talk to medical students and doctors, but the recent high of my life has actually been talking to engineers. We've recently, well, in the last few years, started doing some projects with engineers, and actually the first part of it was coming to speak in a common language. So we doctors, when we tend to speak, we involuntarily tend to use some medical terms which we often don't realize that the person across may not understand. So if we really want to do some different research apart from medical papers and teachings which will be read by doctors to actually advance science, if you look at the history of the best discoveries which have come across in the medical science, they have always been with interdisciplinary collaboration. And I suppose for each of us, academics or non-academics, as scientist professionals, we really need to have the ability to communicate better. So please feel free to stop me wherever if you think I'm talking something which is not decipherable very easily or whatever. The whole purpose is to probably try and advance science, and that must be Professor Shashi and Professor Shekhar's idea in probably having this interdisciplinary kind of lecture. So I really hope we can do justice. So I will probably be talking a little bit on arthritis from the doctor's angle. So it could be a little informative in terms of um, um, some knowledge to apply for our day-to-day lives, perhaps. But apart from that, there is a lot that we could probably do together to advance knowledge, and that is probably what we will stress upon. Uh, it obviously will not be too technical, but what we want is to basically convey ideas and ignite some thoughts. So we would really appreciate if we could make this more interactive. Our team, so I'm a medical doctor. Dr. Bishwaranchan is a rehabilitation specialist. Dr. Khyati Verma is a mechanical engineer by qualification. So we are now like family in the sense we can communicate well with each other. We found one language. So hopefully I will try and communicate the same way with you. And if it is more interactive, it will probably help us think more. And likewise, maybe we can have some collaborative work and things like that in future with more of my colleagues. That's the whole idea. So essentially, it's about arthritis. Arthritis relates to joints. Arth in most of these terms come from Latin. Arth relates to joint. So an itis is an inflammation. So the bone, as you know, is rough and it is covered by these a specific tissue which is cartilage. Now cartilage is one tissue which so far man has not been able to recreate. The person who can recreate this tissue and implant it, so this is a challenge for all the engineers in the world really, and implant it into the human body, could easily be the richest person in the world. There is no doubt about it. Why? Because nobody here, I'm sure, would not have heard the word arthritis. Every single person sitting in this room would have a family member who has complained at some point of knee pain, or have heard of somebody who's undergone a joint replacement or has been referred to as arthritis at some point. So it is something which is a common disease and it is getting more and more common. Now, why is this $1 million industry? The moment that starts wearing away, you're not able to walk properly. And that is why the knee and hip having arthritis becomes more disabling. Movement is the basic for life. It is not about you wanting to have to do an evening walk, but if it is very severe and you're not able to go to the bathroom or negotiate stairs in your house, it can become very depressing. It can give you more problems related to heart and blood pressure and everything else. So life, more than anything else, becomes very, very depressing. So despite whatever advances we have, arthritis is increasing manifold. It is a silent disease. It is not as dramatic as a heart attack, but certainly a lot more disabling than a heart attack. Because once it's happened, it cannot be reversed. Why can't it be reversed? Arthritis means this cartilage, that tissue wearing away. So what happens there? That is the tissue which allows the bones to glide over one another. And when that goes, it does not regenerate. When that happens, no medicine on earth, no engineering can reload that cartilage. And eventually what this is showing is what a knee replacement is. So that's the surfaces of the bones being cut off systematically. Sorry, you're able to see, right, Sanjal? Yeah. And that's how a knee replacement is done. So it might look a little scary. It's not all that scary. It's just on the surface, and you can see how metals are put in, and that's what constitutes a joint replacement. Now, it's just a metal cap. The bone is your own, and just a metal plate which goes into there. But that can change a person's life quite dramatically. A person who's not able to walk or do stairs, we have these people with these things sitting down in temples, walking for 3-4 kilometers, and doing all sorts of activity, kneeling down at churches, riding two-wheelers, or what have you. So, whatever said and done, these operations have made life very easy in terms of quality of life for people. Now, but that is a treatment of end stage arthritis. Arthritis, right from the time that cartilage starts getting irregular, is when somebody can have pain. And everybody need not end up with this. Having said that, an operation like this, if you see hip replacement and knee replacement, out of all the operations that have been done by doctors in centuries, the number one in terms of quality of life ratings, this is not my rating, this is an organization, WHO, which has rated operations as per quality affected life years. That's a parameter. And the number one operation, the best operation on the planet, is a hip replacement. The second operation is a cataract. The third operation is a knee replacement. So, in terms of quality of life, it works wonders. At the same time, if it is not done properly, people would say, rather not have an operation. So these things have to be, rated very carefully. It's not only the mechanics which is important here. The not done properly is often the doctor seeing whether or matching whether that operation is suited for that patient. Now that is different. That is the art of medicine. But when we are talking about joints and engineering here, this itself has a lot of, designing and mechanics to it. But the other parts before that, that is the early stages of arthritis, can very well be treated by modifying your muscles. So there's a lot to learn in terms of, how we are affected at very, very early stages and what we can do to reverse them. Probably, whatever we do, we will never be able to stop our skin wrinkling. Some people wrinkle earlier than others. Yeah, some people lose hair earlier than others. Some people gray earlier than others. We'll never be able to stop that. There's many, many things influencing that. But what we can do for arthritis is we cannot reverse once that white layer cartilage starts softening and withering away. What we can do is probably with our lifestyle modifications, we can reduce the progress of it. And that is why early stages have different treatments. All of which now with deep learning techniques and machine learning have important bearings to not only making the doctor understand and evaluate you better, making you understand yourself better, evaluate treatments better, right from the point of teaching you exercises, which we will be touching upon today. We have done and started a little bit of research on that accord, right from diagnosis to the point of the end stage, that is joint replacement. We can have a machine learning help us at different stages. And this is probably what we'll talk about today. So I will begin with a little bit of explaining to you the spectrum of how early arthritis starts and ends into joint replacement, and show you an idea of what sort of treatments are done. Then my colleague will talk about the earlier stages and what we do along with the treatments, how the rehabilitation and where machine learning can help us there. And our engineering colleague will probably throw more light in your own language, which will help us, I suppose. Okay, so so arthritis, essentially, we know 40% is not just having arthritis, 40% is having severe arthritis. Those are the statistics projected for India. So what we want to do is, at an early stage, we want to see if we can prevent it. What we know for sure is we cannot reverse it. Whether we can prevent it and whether we can prolong the progress is what we'll talk about. Sorry. And at early stages, there are some medications, but again, this is $1 million industry. Every month, two new medications come out. Right from, what's his name? Baba Ramdev's oils to, to lots of paramedic treatments, to, different actors talking about different forms of exercise and injections and stem cells. There's a lot of voodoo being practiced. You put some, right from some ash to some oils on it. It is $1 million industry. There are two new tablets coming out every month which claim to be effective. You can imagine, when too many options are there, it probably means that none of them work eventually. So, eventually, the last stage is surgery. So, what is important, and the first thing I want to say in terms of the medical line is, surgery as such, culturally, is treated as no, 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 I don't want to go there. It is bad. I am okay, at least I'm walking now. What if I'm not walking after surgery? That is the fear there in our 65-year-old mother's mind when she suggested joint replacement. And culturally, that is not wrongly founded, because they have heard of things which were not so standard before. And when medical care was not standard, things, were more unpredictable. So it was natural to not want to go down to something drastic, particularly when there's expenditure involved. So any surgery came with a lot of negativity associated. That's fine. That is culture and mentality. But there are surgeries which we have now with a lot of new developments where we call it preservation surgeries. So it seems contradictory, doesn't it? Surgery and preservation. Surgery means you cut and take away. Cut is a very negative word by such. Okay? But preservation meaning there are surgeries by which we are today, in some conditions, I must repeat, in some conditions, recreate cartilage to some extent. It is not the same good quality natural cartilages. So, but it will work better than having metal in your body. So the first thing I would like to do as a surgeon is, if possible, prevent it. I'm not decreasing my own business, but what I would be probably doing is, if I'm able to prevent this at a larger scale, I would have done some service to humanity. Number one. Number two, if I'm able to avoid that metal and do alternative techniques, what is often, if you Google, it would be called as biological replacement. That is trying to regrow cartilage. If you engineers can make it, like I said, you'd be the most rich people in the world. But till today, nobody's been able to find a material which can go there, stay there, and last. So therefore, it has to be metal. Until I see in my lifetime, at least, probably. Though we can, it's up for grabs as a research topic. So that's one thing. But what I want to say is, there are surgeries which you can do to preserve the natural joint, and I will tell you more about it. In the right situation, if those are done, those will help prevent the progress of arthritis and eventually stop us from putting metal in that joint. And probably a natural joint, whatever said and done, has a different kinematics. So I'm slowly introducing some mechanical terms. Is that okay? Kinematics and things like that. You all are engineers. You all know much better than me. So the kinematics and the surface tribology of that cartilage is something which a superior engineer has made. So whatever said and done, as a doctor, people say you're a god figure, but that engineer above, I must acknowledge, is probably much higher than any one of us can ever make. So if we could recreate that cartilage, I suppose today you had to be God. You couldn't. So what we do by preservation surgery is we try to create an environment which is better than the metal, because the kinematics of the natural joint is such that normal metals cannot take it. Cartilage is an entirely different structure which we couldn't engineer the way it is. So that is a different discussion altogether. So what do I do as a practice, as a specialist? I'll just show you two examples. You have to burst a cracker. You could do it in an unplanned manner, It's a technique. You could do it like that, and if you don't plan it properly, you'll end up in your own mess. So that is similar to what happens with a failed operation. The same thing, if you do in an organized way, that's definitely a thing, organized, planned, but you can execute it with flawless success, and then you become a showman. The world awes at you, correct? So, like anything else, good execution of treatment, the treatment is the same, the metal is the same. It's how you implant it. You put it in somebody who needs it, put it in the right way. It's not, there are these myths, patients come to us saying, you put that imported metal. They think putting an imported metal, everything will be okay. And I have to beg and tell them, you don't have to do that. It's about, when you go and buy a car, you don't have to buy the BMW and then run it on Indian roads. It's how you drive the car, how you service your car. That is what matters. So that is one thing. So what do I do as a practice? I don't like to be, the corporate hospitals would like to introduce me as a knee replacement surgeon, because that's, 80% of my work is working with metals. But I would like to call myself a knee surgeon, and that is why I would be as passionate towards comprehensive care of the knee. So this is what we've registered as what we call our center of excellence. So a center of excellence means we are doing treatments at par where we compare our results only with the best in the world. And if we don't match that, we don't want to do it. Simple as that. You don't compare with, just people around you for competition's sake. What you want to do is, you want to be a scientist, you want to evaluate practice and keep changing techniques such that you are in line with what is best available in the world, so you can offer the patient the best. And if a patient can be cured with the injection, or with keyhole surgery, or with complex metal surgery, or with robotics, and kind of failed surgery and all that, we should be able to do all these aspects of it, or prevention, or exercises. We have an entire team which handles it from, what we can say, from the tomb to the womb, or rather, no, sorry, from the womb to the tomb. It should be the other way around. And that's why we call it comprehensive knee care. It's easier for the patient from the information side. What happens in our healthcare today? People, they have knee pain, and if you go onto Google, you will see sports injury specialist, you will see arthroscopy specialist. How does the patient, Amma with knee pain, understand that she needs to go to the arthroscopy specialist or whether she needs to go to the joint replacement specialist? That's why we like to call ourselves, we are knee and hip related specialists. So that's what we consult in. Anyway, now talking about cartilage a little more objectively, I'll just get into the nitty-gritty of different aspects of things, and then we will look at the engineering side of it. So, that was the cartilage, where it can get a bit soft, it can get less than, it's about a thickness of about 5 to 6 millimeters on different surfaces. So depending on whether it is soft, whether only the first 2-3 millimeters are damaged, whether more than that are damaged, or whether underlying bone is exposed, that's how it's graded. Now, in the early stages of damage, there's nothing we can do, because what we implant, even like I said, in certain situations, we can recreate that cartilage, even if the body has 50% of what God is given, it is still better than what I could recreate. So, nothing better than that, nevertheless. Sadly, we, like everything else, we don't appreciate what God has given, and we damage it in various ways ourselves. And then we want it rectified, which is not that easy. Yeah, it's basic philosophy, isn't it? So we can make a difference even at this stage. No, I can make a difference and grow cartilage only if it has gone to this stage. Because even at this stage, a lot of people will be painless. So pain and a limited area of cartilage loss may not correlate. So even though a lot of medicine is all about pain, so if you have fever and pain, those are the main symptoms for which you go to a doctor, whether it is pain in the head, pain in the knee. People think that if they have knee pain and they go to Yogeesh Kamath is going to take a knife, cut their knees open and put metal inside. That's not the case. In the sense, even with this, there could be people who have no pain. And with this, there could be people who have lots of pain. So it doesn't always correlate. So that is where the doctor's expertise, not in doing the surgery. The surgery I could teach a technician to do. But it is for diagnosing who needs what rightly. That is the medicine part of it. And seeing whether a treatment would be relevant. But what I will tell you from the machine learning, and that's what we will use machine learning, we are trying to get to at each of these stages. Because at this stage and this stage, an X-ray would look pretty much normal. With machine learning, we are trying to get to a stage where we would be able to identify problems by the time this synthesis happened. So we are getting success there. We will show you some papers there. My colleague will talk about it. But at this stage, I could then do surgical treatments, and if the cartilage is gone in a small area, or rather in a circumscribed area, this is what we would call an ulcer. An ulcer is like a patch of skin with proper borders where skin has come out. So similarly, if cartilage has come out in an area with properly circumscribed edges, it might be 2 centimeters, it might be 4 or 5 centimeters, I can make it grow. But if the whole surface is gone, nothing can be done. Then it has to be a joint replacement. People don't get this right, and that's where a lot of marketing in the healthcare industry happens, and that's where despite the plethora of information available on the internet, people go wrong with treatment choices. So pain at this stage is going to be very well cured by Baba Ramdev's oils. Okay? And people think they were walking like that, they walk better. No, it's not from here. That will never happen. It's from these stages. That is where Dr. Bishwa's techniques will probably work better than Baba Ramdev's oils. Probably. Or both of them together will work better. We prescribe a lot of Baba Ramdev's oils. Why? It helps the patient, and we make them do the exercises. That's what we do. We have to be passionate. You have to, what can I say? A lot of medicine is getting to and treating the mind of the patient along with treating this thing. It's for, if it benefits them, why should it not help us? Why not? We don't have anything against any branch of medicine. As an allopathic doctor, I shouldn't have anything against any other branch of, they all have their own backgrounds, whatever said and done, which is good, and we need to have respect. But if it is in this stage and it is circumscribed, I can do preventive treatments without implanting metals, and if it is gone, that's where it is. So that is where my job as a doctor comes. Who gets what? Now, diagnosis of cartilage is important. There are about 15 to 20-year-olds, a lot of 15, this goes between 15 and 25. Boys playing football can get surface fractures like this. So a car which is banged by a two-wheeler, for instance, or anywhere on a busy road, it will not stop the car, but afterwards you'll go and see the dent. So this is like, similarly, you fall down, you don't see a fracture on the x-rays just because there's a dent. This can be diagnosed if looked at properly. But if that is missed in a 15-year-old, that could become a focus point for him developing arthritis in another 10 years. And then nothing can be done. If it is missed at this stage, this is what happens to it later. Now that is an ulcer about 2 by 2 square centimeters on his knee, on the weight-bearing part. So you can imagine a big pothole on a road, a car keeps running on it, the car tires are going to get damaged. So what would you do if you were the engineer and you had a pothole on the road? You'd probably go and do a good patchwork. A patchwork doesn't become as good as a newly tarred road, but it can manage. That's the same thing I do with cartilage in the knee. So I can grow cartilage with stem cells in that kind of damage. But if the whole surface, the whole road is gone, patchwork is not going to work. Then it becomes an experiment. There's no point just spraying sand like our fellows will do, our corporation will do. Every time the rain comes, they spray sand, and one more rain comes, the whole road is gone again. So that time you have to do a resurfacing. That's like a joint replacement. So there are many techniques for stem cells and these work. So what I do regularly, we are the first center in India to actually get, being in Mangalore, we are a very small center, but we've got official recognition by the International Cartilage Regeneration Society. This is actually well established. It's called mesenchymal cells. So what we do is, we take from the patient's bone marrow, there's just a needle going inside, not very scary. So you have marrow, bone marrow, which regenerates blood. So we take bone marrow, we centrifuge bone marrow. From bone marrow, we get precursor cells, which form all sorts of blood cells. So those are like stem cells. When you say stem cells, it is not legal in India to use the embryonic cord stem cells for treatment yet. They are supposed to be used only for research purposes, because a stem cell is a cell that can grow into anything. So if it can be magic, but potentially, we don't know. You take a cell and you put it inside and it grows. Suppose it grows into a cancer. How do you know? It can grow into good tissue, it can grow into bad tissue. So you have to use it in careful engineered conditions. So that's what we do. This has been very well documented. Only from there you put it localized in the area without letting it spread to anywhere else. It's like you take an orphan and you put him into a policeman's house. He's more likely going to become a policeman eventually. Less likely he's going to become a robber. It's like that. That's what you hope. So same thing in the human environment. So that when you put it in a protected environment becomes cartilage. So that's what it does. There are other ways. We have artificially engineered materials which can be put in similar ways, but we have from the bone. If you saw that previous slide there, here is the bone. If I puncture that bone, what am I going to get? Bone marrow. The bone marrow will have the same thing which I get from my injection here. So if I get the cells from here itself, I can give it a good substrate. And if I prepare an artificial substrate properly, that is a technique that can also give comparative results. So this is what we call when we do stem cell work. Now coming to other aspects of engineering where we can use early diagnosis. That's a hip X-ray. That looks, for you, of course, it's an X-ray. But to many doctors, even to me, 10 years ago, that would have looked normal. Earlier, when we had young people coming to us with groin pains after doing trekking and activities which require a lot of this, like football or hockey. This particular guy was playing hockey, and he was going around thinking it's a hernia. Some people thought it is some kind of what is it called? Groin? The sportsman's groin. Yeah. So they have pains here, which many people don't find reasons for. We used to do X-rays, we used to do MRIs, and still not be able to find problems. Now we've got good at the MRIs because we diagnose something called hip impingement, which is a precursor for hip arthritis. And now we know that, we realize we could actually retrospectively see it on the X-ray. So now, 10 years later, what I used to do MRIs for 10 years ago, I don't do now as a specialist. So it doesn't mean I have to be reliant on technology. What the brain knows, the eyes only see what the brain knows. So now that I know, now my eyes can see that just drawing the lines on the X-ray, I can see that on one side, the lines are this way, one line they're crossing. That just tells me the cup is aligned differently on both sides. So if it is aligned in a slightly different plane, actually, that's where in this position, it is impinging. And I can diagnose it on the X-ray. But some people, if they didn't know, earlier we would find it difficult to diagnose on the MRI as well. So this is an MRI, we used to do MRIs. The MRI shows in this area, I can see a little white. And there should be a triangle here where I'm seeing black. That has become white. So to do that, I have done the MRI, which costs something like 8,000, put a dye, which costs another 4,000, and an injection to the patient to diagnose what today I can diagnose with an X-ray. So we can easily, with good imaging software, train our X-rays to diagnose these things for us very well. But also the constraint is getting good standardized X-rays. It doesn't mean just digital X-rays, but positioning patients for x-rays. So that standardization and machine learning has to go a lot with standardization and training the people who take the x-rays in the x-ray lab. So that's that. And now looking, oh sorry, anyway, with cross sections again we do angles and things like that. That's where a lot of imaging software can be used. There are MRI techniques which, if done properly, we can diagnose those cartilage problems and all that early. Having said that, on that note, I will just say that at least 90 to 95% of MRIs, not only in our country, in the world, don't report exhaustively. It's unfortunate that in practice people think, oh, this image is not good, let's repeat the MRI. Doesn't make any difference. Doesn't make any difference. So we are spending money in the not necessary place. If we train our people to read it better, and potentially lots of uses of software and good learning by creating good protocols with the same MRIs, we should be able to report better and diagnose these things at an early stage. When it comes to ligaments, so when I say knee preservation, a lot of people you would have known with injuries, youngsters having ligament injuries, cruciate ligament damage and cartilage damage and things like that. So that can be reconstructed very easily. With good rehabilitation, you can make them go back to sport. What is very common, sorry, my mic is on, am I too loud? Not too loud, no? It's okay, yeah. I forgot I had a mic. I thought I was talking too loud. Suddenly, I suddenly felt it. Okay. So with knee ligament reconstruction, many people would go for surgery, but have or be told that they have, say for example, an ACL damage. When a surgery is being done, one has to look at all of the forms of damage. If it is not diagnosed correctly, many times injuries are half treated, and then you wonder why somebody's had, say for example, a ligament surgery, but they've not done that well, they've not gone to sport. Probably because the other things associated were not diagnosed in the MRI. So a surgeon who's treating should also be able to read the MRI. There are times when I would find in reported MRIs at least 25 to 30% of them, because when I examine the patient better and I try to correlate it, then I see more problems, and then I go back to the radiographer who tells me, yes, that could be there, I missed it. So it's got to be teamwork between doctors to treat better. Usually in statistics, if in our doctors' conferences, when they do ACL surgery, 90% of the time it is just ACL. This is my own statistics. My isolated ACL is less than 25%. So you can see how common the other associated injuries are, which I do along with ACL surgery. Just goes to say a lot of things are actually missed. And common lesions are the surface cartilage, ligaments, you can have what is called the cushions, and whether the axis of somebody, genetic influences also have to be taken care when we do these surgeries. Just to give you an example. So, for example, this particular man, he was having a knee injury and walking around, had gone to some 3 doctors where, he was using this kneecap for 2-3 months. He was having tablets. Now, simple thing, he was walking around comfortably. But a simple thing which was not noted is when he was lying flat, you can see this leg touches. I hope that image is reasonably okay. This leg touches the ground. This leg is deficient of touching the ground by about 5 to 10 degrees. That is a major problem, which nobody advised an MRI. He had an X-ray. But that doesn't require an MRI. That's plain, simple, obvious. Just looking at it, you come to know he's not able to straighten the knee fully. That is something very, very basic. If this gets neglected, that person will require a joint replacement in about 6 to 7 years. We know that from the natural history. Unfortunately, we are not using the diagnostic modalities properly. So that is a picture of his during a keyhole. That's just a 4 mm cut where a camera goes inside the knee. That is the thigh bone, and you can see the cushion of the meniscus is flipped. It's torn and flipped and stuck inside, preventing the knee from straightening. It is easy to put that back. That's how it should be. It's a shock absorber. But that whole thing had flipped, and it is lying here, sandwiched between the two bones. That can be flipped and repaired. It is very, very easily available. But the facility to do this is often not there in many hospitals which advertise themselves as specialty, kind of treatment centers. When we use X-rays and all that, rather than unnecessarily repeat MRIs, there are different digital ways of combining X-rays to actually measure a person's alignment. We will be talking about that when my colleague talks a little bit about genetic influences and how genetics influences our bone shapes. That needs to be corrected if required, if it is causing symptoms, rather than waiting for that to become severe and require a joint replacement. Like you can see somebody whose leg is pretty well aligned here. When you do a mechanical axis, that is the whole person's skeleton, God has designed it such that the center of the knee, the center of the hip, which is here, the center of the knee and the center of the ankle will be along a straight line. That's called the mechanical axis. If the mechanical axis is deranged, and some people get it because this bone is bowed. A lot of us Indians have a bowed bone here. Some of us have a bone bowed in the opposite direction, and that will automatically cause a little derangement in the mechanical axis because of genetic influences. Some of us have it bowed in the rotational plane. All these things can be detected and looked at in the way people are walking. Sometimes we can make out in children when they fall, ever so often in their teenage years, and we can probably try and give them corrective exercises to help load the joint more effectively. Now, if that persists, you can see over time how there is space. I hope the contrast is reasonable to see that, but there is space between the bones here, and here the bones have come close together. I don't need an MRI to tell me more. That space would have normally been occupied by the cartilage structure, and here that is gone. I can see the bone touching the bone. That's why you see space between the bones, because I told you about that cartilage right in the beginning. That is gone here. That person requires something. Now, if I pick it up sufficiently early, I can realign this bone, recreate that space. I've just realigned it because this is more bowed. I work out the bowing individual angles, and I can prevent a joint replacement. This is a temporary plate and screw pin which is put there. Once that heals, that can be taken out, and that can give the person a natural joint for a longer time. If it gets beyond that, I don't have to do a total joint replacement. I can get away, just depending on the type of patient. Okay, I can go about doing a partial joint replacement. So there are various techniques there, which is a part of preservation itself. Going on from there, there are partial joint replacements available for different compartments. This is something which we have with technological developments. We can use them in the right indication. Again, with a good joint replacement, we can give somebody absolutely normal quality of life. That is them kneeling down after about 2 months. You can see people walking in a park normally. That is what people should be able to get. If they want to sit down, they can sit down if it is engineered and executed properly. Failures do happen. Failures with a metal. No metal is going to last as long as a natural joint lasts. Now, see, when the metal fails, it can fail for various reasons. This was something which was done about 40 years ago. If that metal survived 40 years, it's done a good job. The real technical failures are those which fail within 5, 10, 15 years. That shouldn't be with the metals we have in this day and age. But when metals fail, you can see the residual void in the bone. That would have been put here and whatever was made to create the shell is in bits, and the bone is entirely a big void over there. So when that has to be redone, you have to, the bone around there has dissolved because of the reaction. So when you take that out and put, so I had to do the second operation because that was done 40 years ago when probably I was in my nappies. This has to be reconstituted with some kind of big structure. You have to put this defect I have recreated with donated bone from a dead person and filled up the defect with different sorts of metals. You can't get anchorage in this bone, so you have to go below that to get anchorage. So this metal would be from there to there entirely. But still you can restore it back. And there are ways to do that. All that kind of thing to plan. I can get customized metals, I can size it from here to there, get metals to the point where it is made exactly of this size, because every company may not have it on the shelf. I have, like you have Lego building blocks, I can build up blocks with prosthesis. All that is available with technology. I can have different materials I use to cover up defects like this. I can have customized 3D printed implants available and customized for that patient. So these are all the scopes where technology is being used for these things. There is a technology revolution, and towards the end I would talk about conventional treatment versus, reliance on technology. You all heard about computer navigation and robotics being used for joint replacements. So yes, it is making it accurate. What it is doing is, when I cut that metal, all these technologies tell me that I'm cutting it in the right mechanical axis. But we cannot always be slave to technology. It has got to be the doctor working with the engineer. If I go for accuracy, it comes at a cost. So a robotics machine costs, a good robotics machine would cost me something like 15 crores. So to recover that kind of investment, the hospital then charges on an average at least 1 lakh more per patient, because they have to recover that kind of investment. That machine will not stay forever. And what that gives me is, it just gives me whether it is in the right axis, that also in one plane 90% of the time. If I use it well, I can use it well to see tension as well. But for that investment, the actual advantage I am getting is decipherable only about 10 years later or 15 years later. My joints, when joints fail, if they fail like I showed the previous one, fail after 40 years, that's a good job done by a good engineer and a good doctor if it could last and give him good quality of life for 40 years. But despite a good imported implant put with robotics, if that has failed in 5 years, that means it's not the robotics fault. It's probably the implantation fault. Whether the patient used it properly or whether it was implanted properly is the question that follows. So what that does is, intraoperatively, we have markers like this put on the patient. You could have a CT scan which does the planning, and when the surgeon marks intraoperatively, they get a feedback of how you're cutting the bone accurately to the millimeter. Having said that, if it is not done using this, the error would be probably in an experienced surgeon's hands about 1 or 2 degrees. So it will make a difference after 15 years, probably not before that. Or maybe 20 years, maybe 25 years, because with standard joint replacements, we had average good survival of something like 25, 30 years very easily. 40 years was even better. With hip replacements, today I can guarantee 50, 60 years without all that technology. So it's about when to use how much is more important, rather than just using things because it is there and spending money. The failures that happen are often because of things like not taking care of infection. If I'm going behind too much machinery in theater and using machinery, it spends a lot more time during theater, and that can injure the patient's nerves a lot more and create other problems. There's no point having something looking nice on X-ray if the nerve doesn't work and they can't move their leg. So what we are working on is trying to get more simpler devices for which we are using AI again, where we use spacers and check the tensions. You can see these are bone models which we are working on, and as you move the joint, these are giving us feedback with sensors of the kinematics. So we know that even if it is 1 or 2 degrees a little bit this way and that, it will last for 15, 20, 25 years, which is okay for my patient when I do them at 70. Rather than make them spend 1.5 lakh more, this will give me handheld technology with AI, with something which I know, which will have a isometric kind of tension all throughout, and will allow my amma to sit down in a temple, which will give her more satisfaction than having a more beautiful X-ray. What we are also working on from the rehabilitation side is technology like this. Now look at this lady who's walking pretty much after a surgery. Now she was not walking very much outside the house, so she's very happy that she started walking. But today, everybody used to be happy, and the parameters all say she's okay. But looking at that, I'm not happy, because if she's walking, she needs to walk without swaying from side to side. Here she's holding her knees very rigid and she's walking like that. So the habit she had of walking like this with arthritis, that has persisted. She doesn't have pain, but she's still doing that. With good training, with feedback techniques on muscles, which we are working on, which my colleague will talk about, you can see this lady walk after a few months. Do you think it's a little better? This is with feedback, again with machine feedback. My colleague will tell you more about it. So we try to do a little bit of public education. We have a website where we do it. That is the inspiration. I call it Niki Baat. And we do little videos. That's our website, hipandknee.in, where we try and we think it is part of our role to educate the general public. Thank you. No, that was different. Actually, you can see she was, yeah. But we have just started this kind of thing 6-8 months back. So to make it more effective, I had her video in a room. So that room video I couldn't compare to this. So I just took somebody else's video. That lady's video we hadn't got at the time. So but yes, I mean, they are all serials. So we are collecting the data now. We will have much more to show. So I wanted a road, so I just picked up a road of 2 similar ones. I'll ask Dr. Bishwa to take over with the next part. Any questions so far? How to prevent? The answer is coming.
So the answer is actually with all of you. I am here just to tell you. I am not going to do much. It's you who has to know what you are having and how to prevent it. So Dr. Yogeesh have explained about the different preservative aspects, as in keyhole surgery, as in talked about stem cell. He talked about AI in different medical science, particularly related to the knee and hip, and he talked about the surgical aspect. So that makes my job easier because I just have to rehabilitate the patient, and that starts with something like this. You can see this patient who is a 60-year-old businessman. He used to walk probably a kilometer, but you can see how he is walking. Both the you can see both the knees are bent, and that is where Dr. Yogeesh comes in picture. He does this, and then I take over. You see the patient walking on the same day. Probably you're not able to see the wound. We have operated on the right knee, and the patient is able to walk literally within 3 to 4 hours. Why it is required? Because walking on the same day or just getting up from the bed itself can reduce up to 50 to 60% blood related complications, which involves DVT, blood clot, and stuffs like that. Now within two days of surgery, you can see he started walking with sticks, almost getting back to normal. So literally within 3 to 4 days he has done stairs and gone home. Now this is about the surgical aspect, which is much easier because surgically it has been corrected. So my job is much easier. Just have to tell the patient these are the muscles you need to use, these are the techniques we need to use, and that's how we can modify it. But the important aspect of knee arthritis is not the surgical aspect. That is the end stage of the condition. Our role as educated people, be it the medical science or the technical side or engineering side, to try and reach more people so that we can prevent it before it gets worse. And that is why technology makes a lot of difference. The answer to the question how to prevent, that's the best way: lifestyle modification. Now how many of us does exercises regularly? Out of probably 30 or 40 people in this room, I can probably say 2 or 3, if not more than that, because we are always busy with something or other. And what happens? We don't have time, and that gets Dr. Yogeesh into the picture by making his practice more. So my role as a colleague, as a preventive specialist, to make sure the patient doesn't reach Dr. Yogeesh. So you have to prevent it as much as possible. Exercises can be done easily, but we are more happy having a painkiller rather than going for a walk, because that is much easier, and that can lead to further problem. Yoga definitely helps. These are the sports. You can see somebody who's doing cycling. What we don't realize, being in the coastal part, we have the excellent access to beaches, which develops our body balance, and that is what I am going to touch upon. When you have good body balance, 90% of your knee or hip related problems are actually sorted there, because having good body balance, which is called as proprioception. For example, now my eyes are closed, but I still know my hand is out from my body. How do I know that? I am not getting a visual feedback, but each of my joints are having those sensors which called proprioceptors. So each and every second it is giving me the feedback, giving feedback to the brain that this is how the body is moving, or this is how the hand is moving, or the leg is moving. And what happens in arthritis, the first thing which goes is that proprioceptors. So imagine if you are working on a electronic lab and your sensors are not working, you are basically blind, and that is what we are causing our knees, just not doing the exercises. Then of course diet. Now all of us are tired of having rice dal at home, so we need cokes, burger, we need pizza. We are happy to have more fat or carbohydrate, particularly the things what are available in the market, rather than having fruits or the healthy diet. That makes a lot of difference. We are more happy to take this, and if this is not helping, this is the injection therapy. So all this can help, but only in the early stage. This of course has to be done by the guidance of a surgeon or a specialist. Of course this injection therapy also can be done under him. Now when it comes to arthritis, there are two aspects I would like to focus little more. First thing is prevention. prevention is always better than cure, and the prevention starts from you by knowing what you are doing. Next thing, now if I know how to prevent it, it makes my knee or my joint much healthier, because at early stage when it is diagnosed, the treatment is very basic, just doing simple exercises and modifying your posture. Now here we are working a lot. I am currently pursuing a PhD on this, how to diagnose the arthritis at an early stage, because as Dr. Yogesh in the previous slide showed, up to grade 3 of damage inside the joint, which is the cartilage, can be painless with people, and those kind of things can be absolutely normal in the x-ray, and that is where we are trying to address the problem, because the x-ray and MRI picture comes to more or probably gives us more idea when it is much more damaged. Early stages, even the MRI and X-ray can be misleading, and that is where all this body balance, I'm going to show you what are the things we are doing so you get better idea of that, can help diagnose it before all these changes happens. uh, we have started a startup called Gati, Gait and Posture. So my job essentially is to prevent this and treat it without surgical involvement. You can go through our website where all the details about different types of uh, treatment options are available. It's easily available nowadays with help of Google. Now, uh, another very important aspect of arthritis treatment, ergonomics. Now if I look at probably all of you, what I can notice is everybody, I'll just put a chair so that I can explain you. Now most of us, when you are sitting, have anyone sitting like this? Is anyone sitting like this? Most of us sit like this. See, I can see here Dr. Yogeesh is also sitting like this. I can see couple of people who are sitting this. This is the root cause of arthritis. We don't realize. What we do? We sit like this. Correct? So that is where all of us, engineers, doctors, come to picture, because you are not taking care of your knee. Correct? So somebody has to do something. Simple correction. This ergonomics correction, right? Whenever we are sitting, it's not very difficult to keep the foot flat on the ground. That reduces the pressure over the knee. It's not very difficult to keep the back straight, right? We can have hand rest, we can have good neck support. That is done. So our job is over. But this is something I do see out of my practice. Probably 70% of patient comes with knee pain, heel pain, back pain, neck pain, wrist pain, shoulder pain, elbow pain, neck pain. Simple, right? And you see all of our younger generation, they are very happy sitting in the sofa and holding the mobile phone like this. You tell them go and walk, go and play football. No, I am tired, I have got homework to do. And the homework happens online. See, I can sit like this and do, right? And then we see 30 to 40% of young people at the age of 15 or 20 comes to us with bad back pain, knee pain, which could have been prevented just with this. So essentially the treatment involves us, it starts with us and ends with us. Now there are there are people who doesn't take care of the knee and comes with early arthritis, aches and pains everywhere, and that is where early diagnosis makes a difference. This is somebody standing on a force platform. You can see 4 quadrants of the force platform on which somebody is standing, and this is done with 30-second eyes open and 30-second eyes closed. We as doctors can talk about the aspects which involves muscles, but this is where Dr. Khyati Verma is going to explain a little more on that. This gives a picture like this. So you can see when somebody is standing with eyes open, for example, if I am standing here with eyes open, my body balance is much better. The moment I close my eyes, that is where my proprioceptions are getting activated, because my visual feedback is gone. And what happens? The moment I close my eyes, I start swaying more. The sway can be front and back, the sway can be side to side. And if we can catch those things, you can see the moment he stands and the way he's swaying, the graph is showing a variation front and back, and you can see it is more towards one side. So we have with this, with the help of machine learning, we got an algorithm which will be explained to you later. We got an accuracy of around 91% in detection of early arthritis, and that is, this can show us how our joints are much before the X-ray or MRI changes happens. This is where technology helps us to diagnose this. At this stage, with this we can manage with, just as I explained you earlier, with exercises and lifestyle modification. Now this is of course another young lady with this is one of my colleague who has done a PhD on that particular subject. He is checking the muscle strength. This is a handheld goniometer which tells us the strength in the joint. He is checking it. So anyone who is in the age group of 20 to 30 can easily generate up to 30 to 40 Newton of force in the front of thigh muscle. The moment we sit in a S posture, or do not exercise, or do not have good lifestyle, this muscle strength can drastically reduce. So change in muscle strength is basically asking for arthritis. So this is the first change happening in the body, and she has shown a good amount of muscle strength because she is into regular sort of activities, into little bit of fitness. So these are the things which involves technology to diagnose the problem. Now we have done couple of papers on that which is easily available in the public domain. You can go through it. Now I am doing so that is a static analysis. Now we are doing more into dynamic analysis. This is what I am currently pursuing, objective analysis of walking. So here you can see somebody is walking on a mat, which, and this is a subject which is walking on a mat, as well as there are camera systems which tells us the way he or she is walking. Now you can see here, these are the body angles created by using artificial intelligence. You can see how somebody is moving. That tells us whether the angles at the knee and at the trunk is acted properly, or there is any alteration in that. And here you can see the way the pressure changes in the foot. You can see different graphs coming up. For example, when we walk, we don't put 100% body weight in one position, right? Our foot has three different parts: the hind foot, mid foot, and forefoot. Now every time we walk, we land on our heel, then put the foot flat, then put the whole body, then comes out, the heel comes out of the ground, and then the toe comes up. You can see as the pressure is changing, you can see there are times where you can see this red means the pressure is more, whereas green means relatively less. You can see somebody who is walking on the right side creating more pressure. So that tells me probably he or she is more into little more dominant on the right side. As we have right or left hand dominant, similarly we have right or left leg dominant. So these are the things can make a lot of difference, not only analyzing how somebody is walking, of course it can help to prevent surgery. At the same time, when somebody has got a surgery done, to modify or to evaluate whether they are walking properly or no. You've seen videos, right? Somebody who is walking in a different, like a duck, and with the help of technology, we trained them how to use their muscle properly, and the walking changes. So all these things can be very well done by collaborating doctors and engineers, because you are the people who is going to tell us about all this technology. First, the job is easy because Dr. Yogeesh focuses on the bone, focuses on the joint, whereas my job is to focus on the muscle and the posture. Now, with the help of technology, we have come up with something called virtual reality. Much easier nowadays. You basically, wherever you go, for example, a 3D movie, you get those 3D movies where they give you special glasses. That is part of technology, where you see all these things in a different manner. Virtual reality helps us to do activities without being there in the field. For example, you put the 3D glasses, you feel that you are probably climbing a mountain, or you went to swimming. So that helps us to generate those kind of activities without being there on that particular field. So all these things helps us to rehabilitate much better. Now I would probably put this video so that everyone can correlate. Now lot of time we tell our parents, or our grannies, or our grandpas, oh, with time your walking have changed. Now we know, everybody knows that the walking has changed, but that is more subjective, correct? I am seeing you are walking different, they may not feel it. So how do we make it more objective? One second, just playing in the morning. Yes. Now these are the famous world leaders. We see everybody walks differently. Joe Biden is known to slip and fall quite a number of times. Trump, again different walking style. See, all these things, see, this is also one of the style. It's not that it is abnormal. Probably he is used to this kind of walking style. So all these kind of things can be diagnosed or objectively evaluated. So as doctors, if somebody gives us an objective data, our job is easier, because as doctors you don't get that much of time to objectively evaluate the patient. The moment the patient comes inside the room, they would have tons of problems to explain, and everything may not be simpler to do it in first visit. So that's why an objective evaluation can make a lot of difference by preventing the joint getting worse, as well as if it is operated, giving them the best possible way to rectify it. Thank you. I would ask Dr. Khyati Verma to explain more about the engineering aspect. Thank you.
So, good evening everyone. I hope you are not sleeping. Okay, so as Dr. Yogesh said, and or as Dr. Viswa said, they are doing something to prevent it. It's okay. So now we will see what the objective assessment they are talking about. So since they are seeing the person and just identifying how he walks, whether his walk is normal. When we say normal, normal means the person who did not complain of anything. Even though he showed various type of personality, how they walk. Whether they are walking since the childhood, they are walking the same pattern. For them, it's a normal. But if you see from the doctor's perspective, how you are moving your trunk, how you are moving your knees, based on that, they are calculating whether your walk is normal and not. So here, currently we are working with different aspects. One is the arthritis. The other one is the stability of the whole body. When we say stability, it means we are standing on our foot. All of you have heard about the flat foot, right? So it is sometimes it's a hereditary condition. So if we detect in the early age, we will able to provide a corrective action as well as adaptive action. Suppose I'm an adult, there is no scope of correcting my, the arch of the heel. So in that way, we can go for the adaptive one, where we can have some kind of special shoes which can provide us to maintain the stability. Once you have that various kind of stability problem, or you have the flat foot, then your posture is also going to change. The aspect he was telling, if you have the proper balance, if you have the proper arch, proper feet, your mechanical axis, your anatomical axis aligned, then only you can have a proper stability and your walk can be normal. So here you see, all because of, this is not the result of this, but these are the various abnormal walking, you can say. Abnormal walking can be of various reasons. It can be arthritis, it can be neurological disorder, it can be musculoskeletal disorder, based on your postures. So here what as engineers we are trying to do, we are finding out some kind of characteristic features out of the images we are getting. Based on that, we are going to classify, and we can get the data, we can feed into the model, and with the help of doctor's observation, we can classify. Based on those important features and information, we can train our model in such a way that it can be a good predictor of the disease. Okay. So here just say, so here the first thing we have in-house developed this scanning device. It is based on basically LEDs. We have the cameras on the bottom, and the whole system, once you stand on it, you have to stand, it will measure your weight, and it can scan the data. And the data can be scanned in three different, the normal lighting, white plus green, and this green. What is green light significance? Once you stand on the surface, you will put certain pressure on it. And the pressure, wherever you put pressure, it will reflect the light and it can record it as a green. Then you can have the user interface we have, and we have different matrices, like the quantification we called about. So here we have different matrices by which we can identify the few parameters. And we have some literature we have where they have identified few matrices, and they have done the exhaustive the data collection. Based on that, they have come up with, okay, if you use the single identification, or you can say the single index, what is the accuracy to finding out the flat footness? If you use the combined three, what will be the accuracy? So of course, when you are using multiple indicators at a time, the accuracy will be high. So the similar process we are going to apply over here. So first we are scanning the foot. The device is in-house. And once you scan the foot, then you do the stitching. In the stitching, it's completely foot is scanned. So how you identify where the outline of your foot is? So we have used the SIFT algorithm, where it can detect the edges, where it will be the sharp contours. Based on that, it can come up with the final image, which is this one. So once you have this image, then we can use the segmentation, where we can remove the background noises, because once you stand on it, the lot of clothing, lot of lighting will come into the picture. You need to remove this one. Once the background noise is removed, you can actually calculate what is the maximum point here. From the key point, you can find out the various indices, and you can feed these indices in the ML model. And of course, it is not only these indices, it is the observation. Every picture will gone through the medical professional. He will tell, okay, the person will have a flat footness, yes and no. If yes, what is the degree of flat footness? Okay, so that is important. That is an ongoing project. So once the classification and the identification is done, so with a lot of data, we can get with any range of age. So being in the engineering college, we have the range of 20 to 25 or 30. We are trying to get a data from the school children to see how they stand, how much pressure they put on the glass surface based on the contact area over here. Here you just see The green portion is nothing but whatever contact area you have come across with the scanning machine or the scanning surface. So the same principle we can apply to detect the abnormal walking. As Dr. Vishwa said, while walking you are not walking like this. First you are putting heel, then slowly you go to front, then this will be go up, and again you are putting this way. So in this you are having a force variation or the pressure variation. Okay, the other part is how they are saying, once they are having this pressure, this thing they can see, by seeing that how you walk. He has said, he has operated that lady, and that lady is walking like this, right? So this is the one aspect where he is seeing that the whole body, that the motion of the body is not correct. The other aspect he is seeing with this knee angle over here. So while calculating or while analyzing the data, so we can, so here we have published one paper in this where we find out what is this. This swing is known as trunk lean. This is trunk and it is moving in this plane, it is trunk lean. And the knee angle, what difference you will have if you have a normal knee or if you have the abnormal knee. And similar to that here, if you have what you call the altered gait or there's some kind of problem in your knee or hip, we don't know. Because when you apply a pressure on the foot or on the, while walk, you don't know on which point you are having a difficulty. It can be hip, it can be knee, or it can be our body part. You don't know. So there is a one open source that is known as pose estimation. It is open source algorithm. You can tailor it as per your requirement. So this, in this algorithm, what they do, they have done the exhaustive algorithm where they have lot of data. Based on that data, they have trained the model in such a way, if you put an image of a person, it will identify where your joints are located irrespective of your height or irrespective of your anthropometric data. So in this one, we have used this open pose and we have find out like the lady is like walking in a different this thing motion and this knee motion. So here we have calculated what will be the angle between the knee while walking and what will be the trunk lean if you are seeing me on the front or the right. So if you see over here, so this is what, and as he mentioned, while seeing the patient, if you are standardizing something, so whatever data you have measured, it should be in one plane in some position. So we have asked the person while collecting the data, if you are, first we will ask them to walk. Okay, so the person will walk normally as he likes. We will just make the path, and once he comes over there, we can see how he normally walks. And then we can ask that person, okay, now you can change your walking pattern by putting one pressure, more pressure in one leg and just walk. Just see over here how. So the first one is the normal walk. Here you see how the person walks. So from the side walking, you will able to see what will be the knee angle variation. While coming to the front, you will see how the swing happens while walking front. Okay, now the person has changed. Just see. If you have difficulty in any of the joints, how you walk. So in this way, we can say, if we have these kind of information, it is easy to tell patient, look, once before the surgery, you are walking like this, your parameters are these things. And after the surgery and after the rehabilitation, the parameters have been improved. So if you tell them in the number, now initially your number was 3, now your number is 15, the person will be more happy. Okay, like I said, some of the time what happened after the surgery because of, long time they are having pain and they are moving in that, they are comfortable with that. But if you do the proper correction, or if you do the personalized rehabilitation, which is Dr. Das is aiming for, in that way you can easily treat them. The other aspect of this system is, you can say we have lot of other sensor available, you can stick it and you can have the information. That will give you the more accurate information. But the issue is, not all person are comfortable wearing the sensors. So here by just, you're walking, you can put the camera in front of your gate. Everybody who comes just get recorded, and by seeing the data, doctor will tell, or the algorithm will be trained in such a way, it will say, it might be possible that you will develop this kind of condition in your future. So by these kind of assessments, so here we have used, we have used the LSTM plus ANN model architecture, and the input information given over here is knee angle as well as the trunk lean. So based on this information, we have various nodes in that, and we have tested 1000 depots, and the accuracy of this model is about 80%. So right now, what we are gathering more data, so that we can, suppose, if you wear the pant, the skinny thing, it is easily detectable your joints. But if you are wearing the loose clothes, it's very difficult to identify those joints. So along with these open pose markers, we can have a system where while walking, how much pressure you are putting. Based on that, it can objectively assess whether your system in the future you are going to have such condition or not. So this is how we are doing it. The process is in the process. So it is not yet completed. We are gathering the data. So this is how we are trying to objectively define the rehabilitation process, the outcome of a rehabilitation process, or the outcome of the surgery. And with this, you can say the early detection of arthritis or any kind of a stability problem you can have. Thank you. Any questions?
So what we are doing is, when we know the trunk lean angle is more, it means to me that the reason the trunk lean angle is more in an arthritis is, when I'm walking, for me, like she told you the normal gait analysis, walking is a situation where I stand on one leg at a time. When I stand on one leg, my body is using my hip joint as a lever. So the lever arm is actually the width of my body, the lever is the hip joint, and the force acting across the hip joint is my hip buttock muscle. So if I am leaning more, if this buttock muscle is weak, automatically I become like this, for which, to counterbalance my body weight, I do that. So in early knee arthritis as well, because we lose the normal firing from the knee, we tend to do this because we are not using this as a dynamic lever, we're doing this. We have worked out some papers where traditionally, following knee replacement, people are only strengthening the knee muscles. The video I showed was us then starting rehabilitation at a different level. This is not the traditional physiotherapy. What patients think is physiotherapy after knee replacement and it's over. So that gets over in 1 or 2 months. The patient is tired. We start showing them the videos to influence that a little bit. Do you really want to walk? Have you done this to walk around at home, or do you want to walk outside? The onus is on the patient. But
if they want a better quality of life, this is what they have to do. So if now coming down to the actual data, the greater the lean angle with the earlier static analysis which we showed standing on the force plate, it again could easily be correlated to abductor strength, that is the buttock muscle strength. So we correlated what we were getting there to the goniometer measurement, where you saw the girl who was doing this. So we do that in side lying for this as well. And we could pick up muscle weakness. Then he gives, depending on the muscle where we've seen the weakness, he will stress on that particular exercise. We obviously don't encourage them to come to us or come for therapy. The patient has to do them if they want. But those people who want to make a change themselves would definitely do it. And you saw people like that. Those were different people, but we are gathering more and more serial videos because we've started doing this in the last 1 year or so. So the minimum time we are going to see the difference is at least 6 to 7 months. Because once the lever is better, only then you can work on the power part of it. When we automatically seen, what happens is, so far we've been doing it by subjective analysis, that is by those kind of subjective videos. Now with this, the accuracy of it is automatically going to improve. And we are also correlating it with the electronic goniometer strength with our machines over there. Anything you want to add?
Yeah. So all these things basically gives us more objective data. Objective as in you can correlate it much easier, because as a doctor also what we see is again subjective. So for example, pain, it's a subjective feeling. You might have 0 to 10 scale and it can vary, but you cannot have muscle strength which is subjective, that is more objective. You cannot have the sway subjectively, it is more objective. So when we pick up those things early, we can implement it by rectifying the muscle strength, rectifying the posture, and we can have serial assessment with the device, which gives us more accurate value as in whether whatever treatment or advice we have given is helping the patient or no. So it is for treatment purpose as well as evaluation purpose.
So every time we are getting a spatio-temporal data. So for the normal person, we have some variation, and with the, so we are not just identifying, okay, your walk is something is going to happen to you. We are observing you for a longer time. So they will do the rehabilitation 3 months, 6 months, and in between the patient will do their exercise in their home, and they will see how it varies, whether it's a habit of it or it's actually, the goniometer will tell you objectively whether your muscle has gained the strength or not. So that is how it is planned.
So I would like to thank Dr. Yogeesh Kamath for his informative session that dealt with the basics of what is arthritis, how it is diagnosed and treated, and various AI techniques that can be used for detection of arthritis at an early stage. Thank you, sir. And also I would like to thank Dr. Bishwaranjan Das and Dr. Khyati Verma for their presence and enlightening session. Thank you. So now I request Dr. B.H. Shekhar, coordinator of the workshop, to present a small token of appreciation on behalf of Department of Computer Science, Mangalore University and AICT at all.